Stop share. All right. So it is right at 6 o'clock, September 13th. Here we are. Let's go ahead and share my screen. All right. This is lecture 12, advanced hip number 2. Last lecture, we will have had our muscles, our advanced muscle kneeling, our tendons, our ligaments. So this lecture, we're going to be, and maybe a little shorter this time. We'll see what happens. This time, we're going to look at the perineural protocols and the regional specific protocol, the diagnosis protocols. So we're going to jump right in. Perineural, we'll look at the lateral cutaneous iliahypogastric nerve, anterior cutaneous iliahypogastric, lateral femoral cutaneous, genitofemoral, the obturator, the muscular branches of the femoral, and the posterior femoral cutaneous nerve. I believe if I'm missing the saphenous nerve, if I didn't include it in here, it'll be included in an update, an addendum. From a regional diagnosis protocol standpoint, we're going to look at sacroiliitis, the LumbaSacroPelvic Junction, what we call sciatica. We'll look at Piriformis Syndrome, trochanteric bursitis, IT band syndrome, anterior hip OA, osteoarthritis or impingement. We'll look at strains of the adductor group, the hamstring group, and then quadricep tendonitis. So initially what we want to look at, like we've done in previous lectures, want to look at our 3D kinetic screen. So I'm going to jump right in and let's go ahead and review that. Let me pause here and let's take a look at our 3D kinetic screen. First, we'll look at our cervical linear motion. Again, as previous, we're looking for asymmetries. Understand we're talking about the hip, but we're going to run through the entire piece, getting down into the lower extremities, the trunk and lower limbs as well. So our linear, 10 repetitions there. We'll look at cervical diagonal rotation. Again, what we're going to look at is asymmetry of movement, quality of movement, quantity of movement. If there's pain with movement, there's restriction. And then we want to compare the motion from one side to the opposite side. Again, looking for the same parameters there. As we're going through this 3D kinetic screen and 3KS, I will let you know that we will be performing this as part of the homework. So take a look at this and consider how you're going to apply that to your homework. I do believe this is available on as a video on a separate lecture. If not, it's here, or we can make it separately available. Just let me know. So the trunk rotation and quantity, quality of movement. Here we're going to look at our lumbar linear motion. Obviously, the hip can come into play here. And so looking at it from a side-to-side position for assessing the hip, may actually want to compare this also from the front or the back to look at what may be happening at the hip joint itself. Again, similar for diagonal rotation. It's focused on the lumbar spine, but as we're learning here, a lot of movement in the lumbar spine and in the hips, very interrelated. Limitations of movement, dysfunction in the lumbar spine can definitely affect function and movement of the hip, and vice versa. Three-dimensional movements, great way to pull out any asymmetries, any dysfunction happening in that movement system. definitely related to the hip as well as the back. The figure 4 sitting, simply a pass fail. You can get up to that position or you cannot. Shoulder has very minimal to do with the hip, although I guess we could consider fascial planes and the role that they play. The fascial plane folks might argue a little differently with that. Single leg stents, definitely important for hip function. You want to bring that thigh parallel to the floor and be able to maintain that stance. Similar power through the glutes in the thigh for sit to stand. Quantity, quality of movement, asymmetries, symmetry, left versus right. Again, we're looking at it from a side view. Front to back view may also be relevant. Also for the hip. The forward quarter lunge, we're doing this in 3 different planes. Also do it in a rear quarter lunge. And we'll evaluate, looking for symmetry, asymmetry, left versus right. More neurological than anything. Heel walking, and then toe walking. Quantity, quality, asymmetry. Okay, so think through. If for homework, we will ask to find either yourself or a subject that has some asymmetry with 3D kinetic screen, and then we'll have you evaluate that. So let's come back. And to my moderator, how am I looking? Good? Okay. So let's start with the perineural protocols. So getting into the lower extremity, you're going to find a lot of repetition, especially as we get into the diagnosis-specific protocols. One of the reasons I create a lot of flashcards, if you will, on the app is so that we can keep it all straight. Again, a lot of different things happening in a small space, and there's a lot of overlap. But let's start perineural with our lateral cutaneous iliahypogastric nerve. So we pull out our peripheral nerve distribution, and the red arrow points on the posterior aspect where lateral cutaneous iliahypogastric nerve to provide sensory innervation. And why do we look at our nerve, our perineural locations? I'll just use an example from today. Had a patient came in, had some odd sensory things going on, happened to coincide in her case. She was having several nerves affected, that it wasn't at the spinal level, that they were actually being compressed in the fascial planes as they were coming down. So knowing or having at least a chart readily available to evaluate, where this sensory distribution is. If we know that, then we can effectively dry needle those nerves, see if we can reduce that tension in those fascial planes or those in the muscle where nerves may be piercing through that nerve. Prime example, she was having some weakness in her quads, femoral nerve L2, 3, 4. She also on imaging had strain of her psoas. Well, we'll look momentarily at our 3D anatomy approach, and we know that the femoral nerve pierces through the psoas muscles. It's heading to its location into the lumbar spine. So very important to perform that sensory exam when you're dealing with these issues. So again, lateral cutaneous. Let me come back here. Just trying to roll on. So the lateral branch, the cutaneous iliahypogastric nerve, it supplies the skin of the gluteal region, and you can see right here on the picture on the side uh, there at the IT band or the iliotibial tract, and a little bit more posterior is where we see its innervation. That nerve pierces the internal and external oblique muscles immediately above the iliac crest, and you can see that represented there. Curiously, when surgeons harvest bone from the anterior iliac crest, the lateral cutaneous branch of the Iliahypogastric nerve is the most likely one to be injured. So frequently we do see those patients after harvesting off of the hip, some sensory disturbance right here. For dry needling protocol, we're going to be, it can be ideally sideline, it can be prone. And then our target is going to be that nerve path itself. We're not necessarily trying to needle into the nerve. We just need to get close so they can apply some electrical stimulation and provide some reduction in muscle tone where that nerve pierces through that muscle layer, but also if it's through a fascial component, we can use some directional rotation and manipulate and mobilize that tissue as well to try to free that nerve up. Our primary neural locations here, and that's going to be indicated in red. It's going to be along the iliac crest from the location of the posterior IT band attachment, and it's posteriorly 2 to 3 finger breadths further posterior. And so we'll follow that IT band up, and we'll move just superior to the iliac crest, 2 to 3 finger breadths posterior, and that's where we place our needle. Here, needle length is 1.5 up to 3 centimeters. These are superficial nerves, so depth is very minimal. Even with 1.5 centimeters, that needle is probably going to stay with a little bit of the shaft of the needle exposed. At that area, we definitely have some abdominal contents, so we want to be aware of the terminal location of our needle. If we're going to use a 3 centimeter, that needle needs to be oblique or at a tangent to the skin surface to avoid the abdominal contents. Our secondary locations will be, and it's represented with the white circle surrounded in red, internal and external obliques, and the transversus abdominis. If you recall, that's the position in sideline. Pinch that together between the iliac crest and the lowest rib, and needle through those muscles there. And then since we're in this location, we'll also needle into the tensor fascia lata and the IT band itself to elicit a change there. Lastly, we can come up to our proximal location at L1, which is the level where the lateral cutaneous iliahypogastric nerve is supplied. Okay, so let's make a jump here. Let me share. Find my. Bear with me momentarily as I bring up the right slide. All right, here we are. So here we see the iliotibial band coming up, attaching onto the iliac crest. That nerve is going to pierce through the abdominal muscle 2 to 3 finger breadths more posterior, and that's going to be our initial needle location. Again, superficial muscle, we don't want to go too deep. If we use a longer muscle, it needs to be an oblique insertion. We're also going to, for our muscular pieces, we're going to needle into the obliques, the transversus abdominis, in between the iliac crest and the rib. And we'll also needle into the TFL, tensor fascia lata, and the iliotibial band. Again, this can be a direct approach, or more likely we can thread through those contents from the anterior to posterior or posterior to anterior direction. Lastly, we can come up into the segmental level L1 for multifidus and longissimus. Let's come back. And then let's look at, bear with me one. Okay. Wanted to make sure that I had what I needed there. Okay, now let's move to the anterior cutaneous iliahypogastric nerve. So here on our innervation chart, our peripheral innervation, you can see a small area right along the inguinal ligament that innervates. Lateral to inferior to the umbilicus and beginning right around the ASIS. So the anterior cutaneous iliahypogastric nerve, it passes along the crest of the ilium, and you can see it represented here in pink, along the crest of the ilium, and it enters the internal oblique muscle at the level of the anterior superior spine of the ilium, and it runs through the aponeurosis of the external oblique muscle, and they supply the abdominal area beneath the navel. So the umbilicus sitting right over here. It's hard to see. So it provides innervation in this area. It also pierces the internal oblique and becomes cutaneous by perforating the aponeurosis of the external oblique, and that happens about 2.5 centimeters above the subcutaneous inguinal ring. So we look, let me come back here. So our position is going to be supine. Our target structures are that nerve, and we can definitely apply some electrical stim, a low to mid-range, 3 up to 75 to 100 hertz of stim. Our primary neurolocation is going to be along the iliac crest. From the location of the anterior IT band attachment, we're going to come anterior 2 to 3 finger breadths further anterior. So another way of thinking of that, so TFL is rising up as we follow it up to the iliac crest. We can come 2 to 3 finger breadths anterior. We can also come to the ASIS and take a similar 2 to 3 finger breadths posterior from that, again along that superior to the iliac crest. Our secondary muscular locations, again in the abdominal region, the internal external oblique and the transversus abdominis. And then lastly, we can come back up to L1. So let's jump out. Bring our library back. There we go. Interior, where's that at? It's here. Let me refilter here. There we go. Okay, so for the anterior cutaneous iliahypogastric nerve, so very similar to what we did for posterior, but here, and I've got the oblique still, it's there, it's just hidden, but it's present, and you can see the anterior nerve traveling forward or anteriorly. And so we had mentioned from the same location, we can move anterior 2 to 3 finger breadths, or from the ASIS, we can move posterior 2 to 3 finger breadths with needle placement just superior to that iliac crest. Again, what we'll look at is needling into the abdominals, the obliques, and the transversus. And then again, we'll needle into at the segmental level where the nerve is derived at L1. All right. For the lateral femoral cutaneous nerve, as the name implies, covers a big portion of the lateral part of the thigh. You can see it comes anterior, not quite to midline, but quite a bit, as well as on the posterior aspect. It has a very similar approximation to the vastus lateralis as far as its location. So lateral femoral cutaneous, it supplies the skin of the anterior, lateral, posterior surfaces of the thigh. It emerges over the iliacus muscle at the lateral border of the psoas muscle, and it traverses the sartorius muscle where it branches into an anterior and posterior branch. And so, and we'll look at it closer on our 3D anatomy. We see as it crosses sartorius between it and the inguinal ligament, that there is a potential location for entrapment there. Entrapment caused by compression of the nerve near the ASIS and inguinal ligament, and it's commonly known as meralgia paresthetica or the Bernhardt-Roth syndrome. Treatment is going to be supine. Again, the nerve itself or adjacent to is our target structure. Our primary neural location, we've got 5 things here. We're going to go 1 finger breadth medial from the sartorius distal to the inguinal ligament for its primary location. We'll go anterior to the TFL at the junction with the rec fem. We'll be at the vastus lateralis rec fem junction mid thigh. So that will be here. Second will be here anterior to the TFL, the VL rec fem junction mid thigh, and then the IT band VL junction, vastus lateralis junction, says mid thigh. It's more distally. And it will also be at the VL rec fem junction, 4 finger breadth superior to the patella. We'll also have nerve roots coming from L2, L3, so we'll use that as our proximal spinal segmental needling. All right. Let me find this here. All right. So for the lateral femoral cutaneous nerve, looking at it from a 3D anatomy standpoint, again, that nerve, and here it is, highlighted in pink. Now I highlighted it in pink. So there's lateral femoral cutaneous nerve. Again, you see we get a lot of the lateral aspect of our thigh, a little bit posterior with our sensory supply there. So the most common area of entrapment for this nerve as it comes between iliacus, iliopsoas here, and the inguinal ligament on top of sartorius. So we will come just medial, slightly inferior to the ASIS into this triangle for our initial needle location. That's a nice location to do some unidirectional rotation, bidirectional rotation, some tissue mobilization in that area. We had talked about needling of the inguinal ligament. That would be a nice add-on if we suspect the inguinal ligament to be involved. With that, we would also, because we will be very close, we could even add into this a needling sartorius and iliacus as well for that condition. We'll also come down further. Here we have TFL coming down, so the junction of vastus lateralis and rec fem, right in that area there. We'll come down mid thigh, superior or anterior, sorry, to the IT band or the TFL, sorry, IT band, which is going to be our same location for vastus lateralis, so we can needle there. We'll also needle at the intersection of vastus lateralis and vastus or erectus femoris here. And then we can also come further distally, about 4 finger breadths proximal from the lateral patellar pole at that junction of those muscles themselves. Likewise, we can come back. It's not represented here. Oh, yeah, there it is. At our spinal segmental locations, L2 and L3, for our lateral femoral cutaneous nerve. We'll move to the genitofemoral nerve. This isn't needled all that frequently, although I have on many occasions needled for this. It covers a small intimate area as indicated by the brown area that the arrow is pointing to. Specifically supplies skin of the proximal medial thigh and labia majora, or the anterior scrotum, as well as the cremaster muscle. So for the genitofemoral, obviously there are two separate branches here. For our primary neural locations, will be 1 finger breadth lateral to the femoral artery. So femoral artery is not displayed here, but it's going to sit right here, the femoral triangle. So it will be 1 finger breadth lateral to the femoral artery at the inguinal ligament, and it will come distally into the meat of the sartorius. So we'll just do our muscle test to find that, to get into that distribution of this nerve further distally. And for the genital portion of this nerve, we're just going to come slightly lateral to the pecten pubis, or the interpubic disc, onto the body of the pubis itself, and needle into that area. Very superficial, very cautious, especially on male in this area because of tenderness. But those would be the needle locations for the genitofemoral nerve. We could also come back for our proximal spinal segmental locations at their distribution at L1 and L2. So into our 3D anatomy, we will be the different locations here. So and this is represented slightly differently than the previous picture. Femoral artery sitting right in this area. We're going to be 1 finger breadth lateral to that. And then you can see let me highlight. Let me get a little tighter here. So there's the femoral branch of the genitofemoral nerve. So we can see that it could give us some issue with its proximity to that stabilizing ligament off of that. Again, as an add-on, we may want to come out a little bit further laterally, needle into the ilioinguinal ligament itself to elicit some sort of an inflammatory response there. See if we can make a change on that. Again, that location in this anterior saddle region next to the pelvis, and then for the genital branch, which will be coming right there, we can needle just adjacent to the interpubic disc to needle into or adjacent to that nerve to provide stimulation for that as well. So that is the genitofemoral branch and the genitofemoral nerve. All right. So for the obturator nerve, there's much less of a sensory component, but there is a small piece, and it's just inferior to the genitofemoral nerve that we indicated in this brown area. And so for the obturator nerve, it supplies the muscles of the medial thigh as far as as far as the motor component. It has a very small sensory piece more proximally. Then it merges with more of the sensory nerves further distally, communicating branch to the anterior cutaneous and the saphenous branches of the femoral. It's continued down as cutaneous branch to the thigh and the leg as the cutaneous branch of the obturator nerve. So we'll look at that. Position will be That's rolling on. We'll be supine, and we'll look at our locations here. So our primary is going to be at the merger of the sartorius and gracilis. So it's further mid-thigh on the medial aspect. We'll be at the same junction immediately at the level of the superior pole of the patella. And so we're going to drop, so we'll needle first between sartorius and gracilis, and then we're going to come superior pole of the patella, and we're going to drop needle in that location. And then the third one is just going to be midway between those points. The obturator nerve travels between that. It is a potential site of entrapment. So needling in there for both the muscular piece for gracilis and sartorius, as well as the nerve stimulation itself. And needling here is just 1.5 centimeters. Secondary, we can come in, absolutely hit the adductor longus, adductor magnus, and the gracilis, as that is the muscles that obturator nerve provides innervation to. For those, we would look at 3 to 4 centimeters, and that would be addressed also through that adductor needling protocol we looked at. That we'll look at it again momentarily. For obturator, it would be L2, L3, L4 for our spinal segments. Okay, let's come to our library and look here. Okay, so here in the obturator, I'm going to start with the muscular pieces, gracilis, adductor longus, adductor magnus. As you recall, we had a sideline position where we needled 1 palm breadth or 4 finger breadths down from the pelvis into those 2 finger breadths apart. We also will want to now drop into where sartorius and gracilis come together. We'll want to drop needle here. We'll take that same between sartorius and gracilis down to the superior pole of the patella and drop a needle in that location as well, which is also going to be very similar to our location for the adductor tubercle. So we'll drop a needle there, and then we're just going to split the difference between these two and drop a needle right in between. And so we've got the 3 adductors between sartorius, gracilis, and needle there at the adductor tubercle, and then midway in between those 2 muscles. Again, we can also look at L2, L3, L4 for our proximal spinal location. And that's where our sensory or where the obturator nerve originates. And so that would give us more proximal location to provide stimulation. We'll look at the muscular branches of the femoral nerve. Here, wow, this thing is rolling. So our neural locations, we're going to be at the mid-thigh at the junction of the vastus medialis and rec fem. So we're just going to follow this nerve. Muscular branch is just going to come straight down. And so an easier way to think of that is looking at number 2 here. We'll do mid-thigh at the rec fem. This is our prominent needle location for vastus intermedius. So mid-thigh between ASIS and the patella and needling through that. So that'll be our first location. And then we can move just laterally into at the junction of the vastus medialis and rec fem, that second needle location. We're going to drop down into the bulk of the VMO, which is our normal VMO, our vastus medialis needle location. And then we're going to take a midpoint between the VMO or vastus medialis and this more proximal location and place 1 needle right in between. That'll give us 4 locations for needling for improvement in motor response out of femoral nerve. We can also, because it is femoral nerve, go ahead. We've needled rec fem, we've needled vastus intermedius and medialis. We can go ahead and drop needle on the lateral aspect to catch vastus lateralis and complete our quadriceps. And then from a spinal segmental location, again, we can go up at L2, L3, L4. All right, that's fine. There we go. Again, what we'll do is first needle just directly into rec fem, vastus intermedius will come just slightly lateral to the bisection or the merger, the demarcation between rec fem and vastus medialis. We're going to take our needling location into the VMO itself here, and then we're going to put one right in between these two spots as well. Absolutely. Let's complete the quads by coming out. I don't have it figured here, but we'll drop needle into the vastus lateralis as well. And let's go ahead and look at L2, L3, L4. Now I'm going to take just a moment here, and for fun's sake, I mentioned patient from earlier today. I'm going to hide some things here so that we can take a look. We'll go deep. I want to demonstrate where the femoral nerve comes up. So a nice add-on here, anytime we're dealing with motor weakness in the quads, in rec fem, as you'll see, the femoral nerve comes up and it pierces through at L2, L3, and L4 through psoas major. So if for some reason we've got an excessive amount of muscle tension, if there's a psoas strain, which in this case my patient did have, excessive compression on that nerve can be the culprit for tightness in or poor performance in conduction to femoral nerve into the muscles of the thigh, the quad. So whether needling psoas distally, where we've learned here below the inguinal ligament, lateral to the femoral artery, or whether we take our posterior approach to needle into that. Psoas can be a real issue potentially when we're dealing with that compression of the femoral nerve. So I'm also going to hide, kind of try to get deep here. As you can see, the femoral nerve also sits right in the valley between iliacus and psoas. So anytime we're thinking hip flexor, there's actual reason to consider that nerve could be compressed in between the structures themselves, iliacus and psoas, or as that nerve, and I'm going to rotate so that we can see as it pierces into the psoas itself. And I'm going to fade psoas and then highlight, if I can get it, the femoral nerve. So a lot of potential areas for compression on that nerve. Okay. Again, we could also hit L2, L3, L4. Then the posterior femoral cutaneous nerve. So this is the bulk of the posterior aspect of the thigh, distal to the gluteal fold, indicated in that olive drab color by the arrow. It supplies the skin, posterior thigh, and the distal buttocks. Divisions of this nerve also include the inferior cluneal and the perineal branches. The nerve descends beneath the gluteus maximus with the inferior gluteal artery, and it runs down the back of the thigh beneath the fascia lata and over the long head of the biceps femoris to the back of the knee where it pierces the deep fascia and accompanies a small saphenous vein. It's about the middle of the back of the leg, and with its terminal twigs communicating with the sural nerve. So a lot of intercommunication here. So for our needling location, primary neural locations, we're going to do it at the junction of the medial and lateral hamstrings, the inferior aspect of the gluteus maximus. So we're going to get high at the hamstrings and drop just below the gluteus maximus there. We're going to go to the bifurcation of the distal hamstrings. And then we're going to drop another needle right in between. So that nerve just rides right along, as you see with a lot of these muscles, a lot of the nerves rides along where the muscles meet together. So if we have a hamstring strain, if we have some trauma to that area, some swelling, inflammation in that tissue, whether it's in the muscle, whether it's in the fascial plate, that can have impact on the function of that sensory nerve. Again, for proximal spinal segmental location here, we would look at S1, S2, and S3. And when we get to our complete anatomy, our 3D anatomy piece, we'll look at that. All right, let me dial in here. Let me highlight that nerve. All right, so posterior femoral cutaneous nerve. Coming off of there are the branches of the inferior cluneal nerves, and the perineal nerves they're hidden. There they are. And so those can be needled separately if you've got a gluteus maximus issue. But again, first location at the bifurcation of the hamstrings, we're going to needle right into there at the inferior aspect of gluteus maximus. We're going to drop further to the where the muscles separate at the top of the V notch, where we would normally needle our medial lateral hamstrings, and we'll drop needle there. And then we're going to find a space midway between to needle there. As you can tell, it continues further distally, which we'll address in further in the lower leg. But for posterior femoral cutaneous, there we can also, because S1, S2, S3, just needling onto the sacrum itself, we can find PSIS, and we know here we are at S2, so we can come right above, at, and below the level of the PSIS. Now, onto the regional diagnosis protocols. Like I mentioned, we're going to get a lot of reproduction of locations. Here you're going to find that we're doing a lot of the same things, but I break them out specifically because it's also helpful diagnostically for us to determine exactly what it is we're dealing with, and so that we know what we're doing. One could say that, well, why don't we just put needles in every one of these things? Well, a person could, but it doesn't help us know what we're doing or why we're doing what we're doing. And anytime that we can reduce the number of needles that we place into a patient, the better. So let's start with sacroiliitis. I will slow down. All right, sacroiliitis. It's just an inflammation of the sacroiliac joint, and it's a common cause of common source of buttock lower back pain. It's often due to chronic degenerative causes, and it can be secondary to rheumatic, infectious, drug-related, or oncological issues. Some specific examples of non-degenerative conditions would be ankylosing spondylitis, psoriatic arthropathy, Gaucher disease, hyperthyroid, hyperparathyroidism, and various pyogenic sources. So sacroiliitis itself, I'm not referring to an innominate rotation, upslip, downslip, anything of that nature. Any of those things could create an inflammation of the sacroiliac joint, without a doubt. So specifically, we're just discussing an effective method to decrease that inflammation in that joint. If your therapeutic assessment, you look and you see that there is definitely some instability, if there's an upstep, downstep, rotation, in flare, out flare, then that would probably need to be either mobilized or stabilized to affect the long-term culprit of what's causing the inflammation. This is simply a way to treat the inflammation. Primary locations are going to be the multifidus, longissimus, and iliocostalis. We're just going to go after the muscular piece. We're going to be in that area. Very difficult to differentiate sacroiliitis and separate it from our lumbar, our lumbosacral issue. So we're going to start with our muscular piece. Secondary, we're going to go to the interosseous sacroiliac ligament and the posterior sacroiliac ligament. So here we're looking at our locations right here. And those are the ones that we will get a lot of good benefit with. Lastly, we'll go to the iliolumbar ligament up a little bit higher. And then let's go ahead and hit the interspinous and supraspinous ligaments as well, more medially or more in midline. So let's take a look here. All right. Okay. So for sacroiliitis, number one, well, let's look at our multifidus and longissimus, which from the very beginning, very first lab that we'll have had, 1 finger breadth lateral from the spinous process, slight inferior, slight medial angulation down to lamina. Iliocostalis, if you recall, that's that profundus grip butting up against the iliocostalis, needling more lateral to medial to address that. Our secondary locations, our actual sacroiliac ligaments, we will have one, and we'll have addressed all of these ligaments individually in lecture 11. But for simplicity of application, we're going to come just inferior to the PSIS. We're going to drop even further, another finger breadth below that, and then we're going to be 1 finger breadth medial. So that will be for the lower sacroiliac ligaments. For the deep sacroiliac ligaments, we're going to be medial to the PSIS, and then at S1, we're going to needle superior and inferior, and we're going to angle those needles. The superior, we're going to angle inferior. The inferior needle, we're going to angle superior, and we're going to try to get them to meet at the depth of the junction between ilium and the sacrum, deep in there. Once we get those in there, that is a very dense fascial plane that will require a little bit extra movement, a little extra force to get the needle through that ligamentous sheath. Once we're in there, we can definitely do some good needle manipulation for that. And then lastly, we'll catch the iliolumbar ligament sitting right there with the pink notation, and then the inner and supraspinous ligaments on the sacrum itself. And so for sacroiliitis, that's going to be our bread and butter for that condition. If we have some lateral issues going on, if we have some more proximal in the lumbar spine, obviously something else is going on, but very specific to sacroiliitis right there. All right. For the lumbosacropelvic junction, here, the lumbosacropelvic junction, it's important to be considered as a functional mechanical unit. Frequently in degenerative disease, we see more than one single area of involvement, and it's critical to achieve optimal outcomes to address not only the lumbosacral, but also the sacroiliac joints and the pelvic rotator cuff as a single functional unit. So especially as we get more into it, advanced age, advanced degeneration, we're going to see a lot of comorbidities involved that could involve multiple areas of concern. And so it's very important to frequently look at this as a single unit, not just try to break out the lumbar area or the sacroiliac or the pelvic rotator cuff out over here. Very important to look at all of that as a single unit. Looking at it in that regard, we'll start again the lumbosacral junction. Here we're going to look at longissimus, multifidus, iliocostalis. We'll come in. We'll look at our pelvic rotator cuff muscles. So let's come down. Catch that. Oh, hang on, this thing is rolling on me. The secondary part, we're going to look at the muscles we just talked about in our sacroiliitis, our supra-infraspinous ligaments, our iliolumbar ligament, our sacroiliac ligaments. Then lastly, we'll look at all of the muscles of the pelvic rotator cuff that we looked at initially. Gluteus maximus, medius minimus, TFL, piriformis, and then our lower rotator. So that will bring up everything. Let's go ahead and look at that in complete anatomy. And here you can see that there are lots of potential locations. Do I ever needle all of this all at one time? I'm not going to say I never have, but I'll try to take it in layers. If there's something grossly going on and diagnostically, I'm having a hard time determining what exactly is the problem or the primary problem. If pain is significant, we may have to hit the biggest stuff first, get some relief to begin with. Always, I'm going to start with this lumbosacral business. Muscles here, again, multifidus, longissimus, iliocostalis. We'll get the iliolumbar ligament next when we go to our sacroiliac business, our ligaments that we set here. We'll go ahead and catch the interspinous, supraspinous ligament there. And then lastly, go ahead and hit the pelvic rotator cuff, piriformis, the IT band, and the deep rotators. This is kind of a shotgun approach, but these are a lot of the things that we may need to needle all at one time. If there's multiple comorbidities going on, just treat it as that lumbosacropelvic junction. For sciatica, we're going to talk about different definitions that are out there in the literature. Now, we all have the patients come in complaining of their sciatic being bothered and things of that nature. But basically, the two different things that we think of in the literature for sciatica. One is if pain radiating down the leg, in the buttocks and down the leg, is either being compressed at the spinal level, or if it's being instead of compressed, if it's being entrapped further away from the spinal level, say at the level of the piriformis or through the fascial planes as it's heading down the leg. And so for our purposes, I'm going to discuss sciatica being dependent upon being entrapped more away from the spine, but more in as it's traveling down the path down the leg, say through the pelvic rotator cuff. So for that, for our needling, we're going to look at first our pelvic rotator cuff. With that, going to look at the glutes, TFL, and piriformis and the small rotators. Second, we'll look specifically at the piriformis. Come back to that when we get to Piriformis Syndrome in a moment. We'll look at our secondary location for needling that. The piriformis would definitely be a key issue here. And then lastly, the sacroiliac joint that we'll look at from previously for sacroiliitis. So for that, let's jump on to sciatica. Forgot what I was doing for a moment. So again, we're going to start seeing some overlap. So for sciatica, we're going to start with our muscles of the pelvic rotator cuff. Again, with our definition, we're considering sciatic nerve being compressed as it's passing through this location. First thing we want to do is hit the glutes, TFL, and piriformis. With piriformis, we also want to come and we'll look at it again when we talk about the piriformis for this more proximal location. We want to be cautious of that. Obviously, it's hidden back here, but our depth has to be right. Otherwise, we will needle into the sciatic nerve. And so if you recall our approach here, we're going to palpate this lateral sacral border, and we're going to drop a test needle down onto the sacrum to determine our depth. Once we hit the sacrum and we know what our depth is, we're gonna recognize that. We're gonna move the needle 1 finger breadth lateral, and then we're gonna advance that needle 1 to 1.5 centimeters further or more anterior than we did for our test needle. And that'll get us into that medial aspect of piriformis and let us protect the sciatic nerve, but get both a proximal or a medial and lateral needle location so that we can stimulate that muscle at the same time in both directions. We'll also include the smaller rotators. Obviously, piriformis is the bigger player, but the gemelli below can also contribute to compression there. And so we definitely want to make sure we needle into that. We'll come back, we'll catch then our locations for sacroiliitis, our sacroiliac ligament, iliolumbar ligament, supra and intraspinous ligaments on the sacrum itself. For piriformis syndrome, so according to this from National Institute of Health, it's a rare neuromuscular disorder. It occurs when the piriformis muscle compresses or irritates the sciatic nerve. The pain may be worse, may worsen as a result of sitting for a long period of time, climbing stairs, walking, or running. I don't know. I think I tend to see piriformis syndrome fairly frequently. So I don't know if I agree necessarily with it being rare, but I think we see it more often than that. Our primary location is going to be the lateral medial piriformis. Secondary is going to be, again, the muscles of the pelvic rotator cuff. Again, these things are going to start running together. You're going to see a lot of these things. We need to needle very specifically, very commonly. With most of the things that I see in the lumbar spine that have a lateralization out to the greater trunk in this posterior hip region, I will always needle TFL glute min, glute med, glute max, and piriformis. A nice square of needle locations out there, and then I will normally add in my other needles as necessary. So again, piriformis number 1, pelvic rotator cuff number 2, and then we want to also throw in our greater trunk bursitis and the sciatic bursa of gluteus maximus. So it's not drawn on there, but we'll look at that one in a moment when we get to our anatomy. So back to the library. Close that because I need to add one more here. So again, our primary piriformis. Okay, we're going to catch that. We want to come in and catch our square, TFL glute min, glute med, this location between PSIS and the greater trunk for glute max, and then the protocol for greater trunk bursitis, which we will get to in a moment. But basically, we're going to needle onto the lateral apex of the greater trochanter to land onto the the bursa there for gluteus maximus, and there's one for gluteus minimus. But equally, we want to needle onto, let me get this right here, right there. We do want to be cautious. The sciatic nerve is running just adjacent to that. But anytime we're dealing with Piriformis Syndrome, this the bursa of the gluteus maximus frequently gives us issues of inflammation. And so that's definitely one that we need to add. The sciatic bursa of gluteus maximus, definitely want to add that to our treatment approach. Again, given the location of the sciatic nerve, we only want to do that if we're very confident with our palpation and our ability to identify the lateralmost border of the ischial tuberosity. More often than not, that's going to be a very tender location when that is inflamed, but needling onto that can provide some very good relief. So then to the trochanteric bursitis of gluteus maximus and gluteus medius. It's a common disorder, frequently cause of the lateral hip pain. We've all seen this. We've all heard this. We've all seen our patients get injections for this. Inflammation to the bursa can be due to repetitive microtrauma, such as running or exercise, tendinopathy of the surrounding musculature, gross trauma, including fall from a height with direct compression onto the bursa, where inflammation can be idiopathic without a discernible cause. Treatment modalities are nearly exclusively non-operative, although I have seen surgical intervention. They can include NSAIDs, physical therapy, stretching, cortical steroid injections. We've also seen good evidence demonstrating improvement with dry needling as well. So for greater troch bursitis, our primary location is we're going to hit the trochanteric bursa of both gluteus maximus and medius, which we'll have done that in our previous lecture. Both locations here. We're going to come up. We're going to needle into the iliotibial band, since that's what's giving us a lot of that muscular tension through that IT band onto the greater troch. And then lastly, all the muscles again of the pelvic rotator cuff. All right. Troch bursitis. Okay, again, so our primary are going to be just a direct needle down to the trochanteric bursa of gluteus maximus and medius. There is another, I can't get to it. There's one also for minimus that's tucked way away in there. We're going to catch that one as we needle into the 2 finger breadths above the superior to the apex here. So we don't make a separate needle insertion for that. So primary, secondary, we're going to needle through. We can thread through the TFL, the IT band here. Then we can hit our pelvic rotator cuff, minimus, medius, maximus, piriformis, and the rotators. That with a nice strengthening and flexibility program should give us what we need for our greater troch bursitis. For IT band syndrome here, it's going to discuss it more from a lateral knee pain standpoint. Typically, when we talk about IT band syndrome, it is that friction syndrome, the runner's knee business down at the knee. However, we also know that it terminates more proximally, or it originates proximally at the TFL, and that has an impact on that greater troch bursitis that we discussed. So for the IT band syndrome, we do tend to see that knee-wise anyway. Long distance runners, cyclists, skiers, hockey, basketball, soccer. The IT band, it's a continuation of the TFL, gluteus medius and maximus. Traverses superficial to the vastus lateralis, inserts into the Gertie tubercle of the lateral tibial plateau, and partially to the supracondylar ridge of the lateral femur. So our primary location, we're going to be IT band, the TFL. Secondary, we're going to catch gluteus medius and maximus. Let me get back here. Sorry, medius and minimus. And then we're going to catch the remainder of the pelvic rotator cuff, and then, wow, the bursa of gluteus maximus and medius. So again, we're starting to see a lot of reproduction here. Just looking at this sideline position, you can tell here is our piriformis, glute max, glute med, glute min. We've specifically gone after TFL, and then the bursa, glute max, glute med, and then piriformis and the rotators. So you're starting to see a pattern of some commonality here. So let's jump to T-band. Let me bring the library up. Again, for IT band, our primary is going to be into the IT band. So we will thread through the bulk of that muscle right here. We're also going to, our secondary, we're going to look at gluteus minimus and medius. And then lastly, we'll catch the muscles of the pelvic rotator cuff, gluteus maximus, the piriformis here, the rotators, and for our trochanteric bursa, gluteus maximus, and medius. All right. For anterior hip osteoarthritis or impingement, so I'm leaving a lot more of the vein, artery, nerve in line here so that you can see what we're dealing with. Primary locations are going to be sartorius, rec fem, iliacus, and psoas major. Our secondary is going to be our iliopectineal bursa, then the iliofemoral and the pubofemoral ligament, and then lastly, the pectineus and TFL. So let's just jump straight to our business here. And we do tend to see some real improvement with that anterior hip pain, dealing with dry needling on the anterior compartment. All right. And biggest thing we want to be cautious of is our neurovascular structures. So anytime we're needling here, being cautious. Sartorius is hidden, where it's faded, it's still here. Anything inside the sartorius, adductor longus, inguinal ligament. Here in our femoral triangle, we want to be very cautious. It's not to say we have to stay away from it, but we want to be cognizant of what we're dealing with. Again, we always palpate for pulse from the femoral artery. Our primary locations, again, are going to be psoas, which we've touched on, needling psoas and iliacus. Psoas will be 1 to 2 finger breadths lateral from the femoral artery, distal to the inguinal ligament. We can go further, another finger breadth, and needle into iliacus, or we can needle iliacus just superior to the inguinal ligament. Again, I've left the digestive contents visible so that you can be aware. You definitely want to make a lateral angulation with that needle, because we don't want to get into any of this business. So still a safe needle. Angulation is definitely key there. Person could also, we talked about needling iliacus on a more slender patient from sideline, from the iliac crest into there. My preferred is right here, but also sartorius and rec fem. So sartorius, rec fem, psoas, and iliacus are primary. Our secondary, we're going to needle into our iliopectineal ligament, which is going to be located here. We've gone over the specifics in lecture 11, the iliopectineal ligament, the iliofemoral ligament, which is our location. Where are we here? Did I put it over here? So iliofemoral and iliopectineal bursa in the same location. Iliofemoral, or sorry, pubofemoral is through sartorius deep. And then lastly, we want to needle into pectineus and then the iliotibial or tensor fascia lata here. So again, the biggest issue is being cognizant of femoral nerve, artery, and vein, and using appropriate finger breadths to stay away from those areas, as well as the contents of the digestive tract on iliacus. But needling into this, again, get very good response results from hip OA and impingement. All right, now to our strains, adductor strain. Common cause of medial leg groin pain, especially among athletes. Things involve the longus, magnus, and brevis, with the longest being the most commonly injured. Our primary locations are going to be the adductor longus, magnus, and gracilis. In the picture to the left, you can see that is that sideline 4 finger breadths distal from the pubis, and we're going to needle 2 finger breadths apart to get adductor longus, magnus, and gracilis. Then we'll get adductor brevis and the adductor tendons, which represented by the white dot here. And then lastly, we'll get sartorius and vastus medialis. So try adductor strain. Okay, so remove the other leg. So very first one, our adductors. Gracilis, adductor longus, adductor magnus, 4 finger breadths from the pubis, insert needles, and then direct them towards the table. Our next will be adductor brevis and the adductor tendons themselves, which we talked about last time. We're going to needle slightly away from midline through that adductor tendon to get further into adductor brevis. And then lastly, vastus medialis and sartorius. If we so chose, we could come up a little bit higher and catch it right there. But because of their attachment, we definitely want to include those in our adductor strain. Okay, for our hamstring strain. It can become strained or torn during running, kicking, or even simply walking down steps. The muscle can actually tear, and many people can hear and feel an audible pop when the muscle is damaged. Hamstring pull may occur anywhere along the muscle tendon anatomy. However, it most commonly occurs in the middle of the hamstring muscle. As people age, the tendon can be injured where it inserts the ischial tuberosity in the pelvis and cause groin or hip symptoms. On occasion, the tendon injury can pull a small part of the bone away, creating a avulsion fracture. That can happen with a quick muscle contraction during bursts of speed, such as ice skating, weightlifting, or skiing. So here we're going to look, we'll hit semitendinosus, semimembranosus, and bicep femoris. We're going to catch that more distally. Now, as the article mentioned, that frequently happens mid belly. So we're doing it distally for sake of ease of location. It can absolutely be brought up to mid belly to needle into this muscle group. Our secondary is going to be the sciatic bursa of gluteus maximus that we talked about. and then the hamstring tendons themselves. And then lastly, the sacrotuberous ligaments and quadratus femoris. All right. We are almost there. So for the hamstring strain, we'll start with the distal hamstrings at the V notch from lab. You'll remember we drew this out and needle just away, finger breadth away from midline. So we'll catch the hamstrings there. Absolutely, if we feel it's more appropriate, if we're palpating, we feel more of a ropey structure inside the muscle more proximally. Absolutely, we can needle in there. There's no reason to not. But that's our primary down in the hamstrings. Distally. We also want to come up, and because of their attachment on the ischial tuberosity, we want to hit that bursa of gluteus maximus. Again, sciatic nerve running right adjacent to it, and so we'll needle onto that. We can also needle into the tendons, proximal tendons of the hamstrings themselves. So needle through at that location. For ligamentous purposes, the sacrotuberous ligament can be needled inferior to the PSIS at the sacrococcygeal junction or on the medial aspect of ischial tuberosity itself. And then lastly, because quadratus femoris has a prominent attachment, we want to needle into that as well. That would be that distal needle placement when we redirect on the pelvic rotator cuff. So lots of prominent things that are attaching here that can cause that hamstring strain. If we're feeling it proximally, we need to be addressing these things. If it's more mid-belly, we can catch it there, or definitely I would include these lower needle locations. All right. And then the quadricep tendonitis. Quad tendonitis, important cause of anterior knee pain. It's usually because of overuse, injury, and athletes. However, there's been association found between non-athletic patients who have a little higher BMI and patellar tendinopathy. I can tell you that I tend to see quad tendonitis as well as patellar tendonitis, which we'll talk about when we talk about the knee, in patients who have less than favorable outcomes from knee scope, knee replacement. Those patients that lack terminal extension, a lot of times that anterior knee pain is more a quadricep tendonitis or a patellar tendonitis than it is our customary anterior knee IT band friction and things of that nature. Here, absolutely, first thing we're going to do, we want to catch the quads, rec fem, vastus intermedius, lateralis, medialis. Then we want to hit the quadricep tendon and the suprapatella bursa. Then lastly, the subcutaneous prepatellar bursa, the infrapatellar, the subcutaneous prepatellar bursa, the infrapatellar bursa, and then the patellar ligament. A lot of words. All right. Back to the library. Okay. So for quad tendonitis, goes without saying. All right. Then we need to needle the quad. So we'll catch rec fem, vastus intermedius, we'll catch vastus lateralis, medialis, and then lateralis. And then we want to come into the quadricep tendon itself. Now we're going to be a little bit more proximal here, maybe 2 to 3 finger breadths superior to proximal. Then we want to be right at the patellar pole, superior, lateral, and medial. Make sure that we catch this broad ligamentous or tendinous attachment onto the patella. Then we want to needle the suprapatellar, infrapatellar bursa. And then lastly, we want to needle into the patellar tendon or the patellar ligament itself. Again, for me, key here, needling is great to restore or improve pain and inflammation. It tends to be associated just as frequently with a lack of terminal extension if it's not an overuse issue. So when you're treating that, make sure that you take a look at terminal extension. If not that, then let's go supine or prone, and let's look at full quad length. Odds are we're going to see a length issue on that. Okay, so now to our post-lecture assignment. So as I mentioned, 3 pieces here. One, I want you to submit a sample 3KS video, includes all the components. We're going to go from the cervical linear motion all the way to the heel and toe walking. I want you to submit a brief description of what your analysis is of that 3D kinetic screen with the focus on the trunk and the lower body. Take a look and see if you can identify what's happening. If you can see some movements, that quantity, quality of movement or symmetry, left versus right, if you're seeing some aberration there. And then lastly, what muscles, tendons, nerves, and protocols would you recommend for potential dry needling? So I stopped my share a little bit early. Jump back here. So lastly, last screen here, next on, so for our live session here, our next will be on September 27th, 2 weeks from now, 6 o'clock. And that's going to be advanced dry needling of the knee, similar to the hip. I'm breaking the knee down into 2 separate lectures so we can spend a little bit more time there. So work on that homework. And if there are things that I need to answer, if I can do anything, just yell and let me know. Otherwise, I will see you with homework on the arena, and in 2 weeks on the lecture for the knee.